Welcome to the Radiographics Podcast. I'm Wendy Gibbs. This week on the podcast, we're focusing on advances in knowledge in oncology and effects of cancer treatment. I'm summarizing a very useful paper about the effects of radiation therapy for head and neck tumors on the surrounding tissues, what is normal, not normal, and when these complications appear. Dr. Frederick will be discussing a cutting-edge paper on human oncoviruses, viruses that cause human cancers in immunocompromised patients. I didn't realize how common these are. Let's start with mine. Adverse radiation therapy effects in the treatment of head and neck tumors. Radiation therapy plays an essential role in the treatment of several head and neck malignancies, as a single modality or part of a combined approach. Despite the improvement in radiation delivery techniques, normal structures in the vicinity of the target area remain susceptible to a wide range of adverse effects. Given their high incidence, some of these effects are referred to as expected post-radiation changes, like mucositis, sialidinitis, and edema, while others are considered true complications, meaning they should not be expected and can even represent life-threatening conditions, things like radionecrosis, fistulas, and radiation-induced neoplasms. Also, according to their timing of onset, these deleterious effects can be divided into 4 groups: acute, meaning during radiation therapy, subacute, within weeks to months, delayed, within months to years, and very delayed onset after several years. In this great paper, the authors provide a comprehensive review of the most important radiation-induced changes related to distinct head and neck sites, focusing on their typical cross-sectional imaging features, and correlating them with the time elapsed after treatment. So radiologists need to be familiar with these imaging findings and find essential clinical data at the time of interpretation, including knowledge of the radiation therapy dose and time, the target site, and manifesting symptoms, to better recognize imaging findings, avoid pitfalls, and help guide appropriate management. Head and neck cancers account for only 4% of all cancer cases, but the negative impact on patient quality of life is considerably greater than that of malignancies of other regions. This is because of the possible compromise to important functions such as breathing, swallowing, airway protection, and speaking, not to mention the aesthetic implications. Radiation therapy uses ionizing radiation to damage the DNA of malignant cells. It may be used alone or as part of a combined therapeutic approach with surgery or systemic therapy. Adverse effects result from toxicity of the dose delivered to neighboring healthy tissues. Local damage is frequently intensified by systemic agents such as chemotherapy, which are the standard of care for many advanced tumors. Over the past decades, RT techniques have evolved to mitigate adverse changes without compromising dose delivery to target sites. Nonetheless, expected post-radiation changes remain common, can manifest clinically for weeks, months, or years, and can be recognized by their typical appearance on imaging. Radiation-induced adverse effects are classified as true complications when they're not expected, when they're severe, or potentially life-threatening. Post-treatment surveillance with clinical exam and imaging is commonly performed every 3 to 4 months in the first 2 years, every 4 to 6 months in the subsequent 2 to 5 years, and annually thereafter. In the follow-up setting, the surveillance protocol should evaluate tumor response and check for complications and recurrence, as well as for the possibility of the presence of other primary malignancies. Head and neck cancer staging is usually performed with CT after contrast, and this method provides the best cortical bone detail assessment, highest spatial resolution, and lowest susceptibility to motion artifact, in addition to being the most frequently available modality in oncology services. Within weeks to months after radiation therapy, the most common adverse effects can be reliably identified with contrast-enhanced CT. In patients with conditions requiring more accurate functional or soft tissue evaluation, such as dysmotility or acute transient myelopathy, esophagography and MRI represent the best imaging modalities. In select cases, MRI is performed for staging and follow-up. For tumors that are at risk for perineural spread or dural invasion, such as sinonasal, salivary gland, nasopharyngeal, and skull-based tumors, MRI is preferred. Advanced MR sequences, such as diffusion-weighted imaging, have been reported to be useful in differentiating tumor recurrence from normal post-operative changes in fibrosis. A reduced apparent diffusion coefficient, the ADC, is suggestive of recurrence, since it's related to the cellularity of the studied tissue. It's postulated that the reduction in tumor cells and necrosis induced by radiation therapy lead to an increase in tumor ADC as compared with pre-treatment values. Early adverse effects of radiation therapy are usually depicted as an additional finding by the imaging modality chosen for evaluation. For late adverse effects, the imaging modality of choice is specific to the site and nature of the adverse effect. So, ultrasound for overall thyroid complications, MRI for radiation-induced neoplasms or sarcomas of the head and neck and central nervous system, and upper digestive endoscopy and esophagography for aerodigestive tract stenosis, perforation, or fistulas. Let's discuss some of the radiotherapy adverse effects by anatomic site. We'll start with the skin and subcutaneous soft tissues. These are severely affected during radiation therapy, especially in the treatment of head and neck cancers, where skin-sparing techniques for radiation application are not yet possible. Furthermore, basal epidermal cells are radiosensitive because of their high proliferative capacity and oxygen requirements. Radiation damage to the skin, or radiodermatitis, occurs in more than 90% of patients who receive radiation therapy for their cancer. And it's divided into effects that occur in the acute phase after exposure and those that are evident after prolonged periods of time. So in the acute phase, an inflammatory reaction in the deep tissues usually occurs within 2 weeks after radiation. There's interstitial edema resulting from increased permeability due to the detachment of the endothelial cells lining small blood vessels and lymph vessels. After this period, there's progressive thickening of the connective tissue and endothelial cell proliferation, eventually resulting in the complete obliteration of the vessels and accumulation of interstitial fluid due to reduced venous and lymphatic drainage. How about the mastication apparatus? The mastication tissues are late responding to radiation damage when compared with other tissues, months to years. The muscles frequently show increased T2 signal intensity and enhancement. Increased water volume and vascularization are not specific changes and may be caused by several pathologic mechanisms, including early inflammation and edema, radiation-induced fibrosis, mandibular osteoradionecrosis or muscle denervation atrophy in the later stages, and sometimes residual or recurrent tumors. The resolution of the inflammatory process induced by direct radiation damage can cause trismus from the involvement of the medial pterygoid muscles and temporomandibular joint fibrosis. Let's move to the salivary glands. Major and minor salivary glands are susceptible to the effects of radiation, usually involving the major salivary glands, parotid, submandibular, and sublingual, that are responsible for up to 90% of salivary production. The parotid parenchyma is composed exclusively of acinar serous cells, while the submandibular and sublingual glands have a mixed composition, the latter having a lower percentage of acinar components. Acinar serous cells are highly radiosensitive and die soon after radiation exposure by apoptosis, whereas mucous cells are less affected. It's important to note that the effects on salivary glands are directly related to the radiation dose. Early effects of radiation to the salivary glands include inflammatory and vascular changes and are characterized on CT and MR by edema and heterogeneous enhancement. Late imaging findings include atrophy of the salivary tissue, usually concomitant with fatty infiltration, leading to progressive reduction in gland volume. Parenchymal loss is expected to be more prominent in the parotid glands, but may vary depending on the primary site of the lesion and radiation exposure. Let's move to the pharynx, larynx, and esophagus. In these structures, early changes, the first weeks or months after RT, usually lead to an acute inflammatory reaction of the mucosa, or mucositis, and submucosal edema. Concurrent chemotherapy may result in increased toxicity with worsening of these changes. Thickening and prominent mucosal contrast enhancement of the pharyngeal walls, thickening of the laryngeal structures with increased attenuation and signal intensity of the fat in the pre-epiglottic and paraglottic spaces, and edema or effusion of the retropharyngeal space are some of the RT effects that usually are seen on CT and MR. But note that a focally thicker mucus enhancement line or the presence of ulcerations can be a sign of a viable tumor component. Fistulas may be of the orocutaneous type, leading to continuous saliva spillage, or they may manifest in more critical locations such as the cervical spine, with the possibility of associated spondylodiscitis. The bones. Osseous changes after radiation correlate with the radiation dose. At low doses, fatty replacement of the bone marrow is seen. At higher doses, imaging findings may vary from osteitis to necrosis. Now let's talk about radionecrosis. Radiation-induced vascular wall injury can be aggravated by systemic comorbidities such as arterial hypertension and diabetes, reaching an incidence of approximately 35% compared with approximately 9% in patients without these comorbidities. There are 3 risk factors for the development of radionecrosis: maximum dose, fraction of the target clinical volume greater than 2.3 gray, and depth of invasion greater than 1.2 centimeters. Physiologic change in tissue characteristics caused by aging, especially with regard to vascularization pattern, can make certain structures more susceptible to the effects of radiation. The clinical and radiologic signs of acute, meaning less than 1 month, and chronic, greater than 1 month, osteomyelitis and osteoradionecrosis may be indistinguishable from each other: trismus, fever, bone fragmentation, and sequestrum. The presence of extensive extraosseous collections can suggest a concomitant infectious cause. On CT, there are cortical erosions, loss of bone trabeculation with gas bubbles, and even fractures in osteoradionecrosis sites. On MRI, the site of radionecrosis may have intermediate or low signal intensity on T1, high signal intensity on T2, and increased ADC values. Enhancement is often low, but may be more intense in the adjacent soft tissues. Dystrophic calcifications in soft tissues around the osteoradionecrotic site may also be present. Associated osteomyelitis may be difficult to differentiate from tumor recurrence. The hyoid bone and laryngeal cartilages can also manifest with radionecrosis with radiologic characteristics that are similar to those previously mentioned. For vascular toxic effects, the territory exposed to or in proximity of radiation fields may develop vascular disease. Venous thromboembolism is the most common historically studied complication, but other toxic effects such as vasospasm, acute arterial thrombosis, carotid artery blowout, and accelerated atherosclerosis can also be found after radiation. Accelerated atherosclerosis in the carotid system can be seen in patients after head and neck RT. The mechanism of vascular toxic effects is media disruption, fibrosis, atrophy, and adventitial thickening. The incidence of vasculopathy in these patients ranges from 30 to 40%, compared with 0 to 9% among patients who have not had RT. So that's big. Internal carotid and common carotid arteries are the most commonly involved. RT effects tend to be more diffuse in longer segments than in conventional disease, but otherwise appear similar to conventional atherosclerosis. Therefore, only cases with exacerbated severity in the area of previous RT can be considered related to radiation. When undergoing the same medical therapy as patients with conventional atherosclerosis, patients with atherosclerosis related to radiation usually do not demonstrate similar reduction in disease burden, suggesting that this atherosclerotic process is not identical. Symptomatic patients with RT-induced arterial stenosis may require carotid endarterectomy or carotid angioplasty. Carotid blowout syndrome is a life-threatening complication. It's the result of arterial wall necrosis and be caused by a recurrent or second primary tumor, direct tumor invasion, infection after surgery, reirradiation, or by a combination of any of these factors. It can involve the common or internal carotid arteries and is divided into 3 types. Type 1 is carotid artery exposure at exam or imaging. Type 2, or impending blowout, by episodes of bleeding or sentinel bleeding. And type 3 is fatal carotid system hemorrhage. On imaging, radiologists should look at the direct and indirect signs such as mucosal necrosis, pseudoaneurysm, exposed artery or recurrent tumor adjacent to an artery, and active bleeding characterized by contrast extravasation. That one's always scary on call. All right, in conclusion, despite many advances in recent decades, radiation therapy for head and neck malignancies still causes a wide range of adverse effects, from relatively minor and expected post-radiation changes to potentially life-threatening conditions. By recognizing their typical imaging features on routine post-treatment surveillance imaging or imaging exams triggered by the development of new symptoms, radiologists can differentiate these common or rare adverse effects from disease recurrence, providing crucial insights to guide patient care. All right, that's it for this week's podcast. Check out these articles in the newest issue, online or in print, and we'll post related cases, so look for us on Twitter. And we'll be back in 2 weeks with more summaries.
Human oncoviruses and thoracic tumors. Understanding the imaging findings. Viruses are increasingly being recognized as important in terms of the cause and pathogenesis of human cancers in immunocompromised populations, including patients with HIV and AIDS, and patients who undergo immunosuppressive therapy after organ transplant. 7 oncogenic viruses are implicated in approximately 20% of all human cancers by a variety of mechanisms as uncommon consequences of the normal viral life cycle. Biologic agents have been recognized to have 3 major types of mechanism of carcinogenesis: direct, indirect by way of chronic inflammation, and indirect by way of immune suppression. Direct mechanisms in which the virus-infected cell ultimately becomes malignant are typically driven by the effects of viral oncogene expression and linked to integration of the DNA into host cell chromosomes to maintain the malignant phenotype. 4 viral agents have been identified as direct carcinogens: Epstein-Barr virus, or EBV, human herpes virus 8, or HHV8, also known as Kaposi sarcoma herpes virus, several types of human papillomavirus, or HPV, and human T lymphotrophic virus 1, or HTLV1. This article focuses on these 4 viruses and the types of thoracic malignancies that they cause. EBV is a human herpes virus that is widespread in all populations and carried as a latent asymptomatic infection in most individuals, usually persisting as a harmless passenger. In healthy individuals, an equilibrium exists between latent EBV infection and the host's immune system. Let's discuss the malignancies associated with EBV, which includes Burkitt lymphoma, post-transplant lymphoproliferative disorder, or PTLD, lymphoid granulomatosis, and diffuse large B-cell lymphoma. Burkitt lymphoma is a high-grade B-cell neoplasm associated with EBV, HIV, and chromosomal translocations that cause the overexpression of the c-Myc oncogene. There are 3 clinical variants: endemic, which are seen in areas of malaria and EBV, sporadic, which is seen in areas such as Europe and North America, and immunodeficiency related, as seen with HIV infection. Thoracic involvement is common and most often manifests with unilateral or bilateral pleural effusions that can be massive, causing mediastinal shift. Mediastinal or hilar lymphadenopathy also is seen. PET-CT is the most widely used functional imaging technique for initial staging and evaluation of treatment response. PTLD is one of the most devastating complications of solid organ transplant and hematopoietic stem cell transplant. The EBV genome is found in almost every case. The development of PTLD is the consequence of an imbalance between immunosurveillance and immunosuppression. In patients who have undergone hematopoietic stem cell transplant, PTLD more commonly originates in the graft donor. On the other hand, PTLD in the setting of solid organ transplant usually originates in the graft recipient. The incidence is highest in patients after lung transplant. While the highest incidence of PTLD occurs in the first year after transplant, the time that it occurs varies between 1 month and 10 years. The clinical presentation of PTLD is grouped into 3 syndromes: infectious mononucleosis-like, isolated or multiple tumors, and widespread fulminant disease. The imaging features of intrathoracic involvement by PTLD are similar to those of non-Hodgkin lymphoma in immunocompetent patients. The most common intrathoracic manifestations, seen in half of cases, are randomly distributed and well-circumscribed pulmonary nodules, which have a peripheral and basal predominance. Less commonly, nodules manifest with an associated hazy halo or central necrosis, a finding that can mimic invasive pulmonary aspergillosis. The main differential for PTLD in immunosuppressed patients is angioinvasive aspergillosis. Tissue sampling is necessary to differentiate. Other intrathoracic manifestations include mediastinal and hilar adenopathy and airspace consolidation. PTLD has a propensity to involve extranodal sites, the gastrointestinal tract, the thorax, the central nervous system, and allografted organs in particular. Lymphomatoid granulomatosis is a rare EBV-positive B-cell lymphoma that involves the lungs as bilateral nodular infiltrates. Extrapulmonary sites of involvement seen at diagnosis are highly variable, with other commonly affected organs including the skin, central nervous system, and kidneys. The most common radiographic and CT features of lymphomatoid granulomatosis, which are seen in most cases, are peribronchovascular lung nodules that are generally sub-centimeter in size and demonstrate a lower zone predominance. EBV-positive diffuse large B-cell lymphoma occurs in individuals who are older than 50 years and have no known immunodeficiency or history of lymphoma. If there is a known cause of immunodeficiency, these tumors are better classified as PTLD, or other iatrogenic immunodeficiency-associated lymphoproliferative disorders. Lymph node involvement is very common with EBV-positive diffuse large B-cell lymphoma and is seen in 70% of patients. Let's move on to HHV8, which causes 3 cancers: AIDS-related Kaposi sarcoma, the plasmablastic form of multicentric Castleman disease, and primary effusion lymphoma. Kaposi sarcoma is an endothelial cell neoplasm which has 4 variants: classic, African, organ transplant-related, and AIDS-related, which all have identical histopathologic characteristics. CT manifestations of Kaposi sarcoma include peribronchovascular interstitial thickening and irregular or ill-defined opacities with a middle and lower lung predominance. Other common findings include interlobular septal thickening, fissural nodularity, lymphadenopathy, and pleural effusion. Thoracic manifestations are common with AIDS-related Kaposi sarcoma and are usually preceded or accompanied by mucocutaneous lesions. Kaposi syndrome may involve the tracheobronchial tree, pulmonary parenchyma, and pleura. Lesions in the bronchial tree below the carina are commonly accompanied by parenchymal findings. Castleman disease was first described as a chronic nonspecific inflammatory process and is also referred to as angiofollicular or giant lymph node hyperplasia. However, it is now considered to be a heterogeneous group of rare lymphoproliferative disorders. Castleman disease occurs mainly in the mediastinum, 70% of cases, or less commonly in the neck, abdomen, and pelvis, and involves primarily lymphatic tissues. Castleman disease is divided clinically into unicentric and multicentric subtypes. Unicentric Castleman disease is characterized by involvement of a single lymph node region and typically demonstrates an indolent course with progressive enlargement of the lesion. It is not associated with HHV8. On the other hand, multicentric Castleman disease is associated with HHV8 and is characterized by episodic systemic inflammatory symptoms, reactive proliferation of benign lymphocytes, and multiple organ system impairment because of excessive pro-inflammatory cytokines. Radiologically, typical multicentric Castleman disease manifests as generalized thoracoabdominal lymph node enlargement, which shows avid enhancement. Diffuse pericardial and pleural effusions, ascites, splenomegaly, and hepatomegaly may also be seen. There is significant overlap in the imaging features of multicentric Castleman disease and lymphomas because both often manifest with homogeneous multi-station nodal involvement. Lung parenchymal abnormalities include centralobular small nodules, thin-walled cysts, thickening of bronchovascular bundles, and interlobular septal thickening as a manifestation of lymphocytic interstitial pneumonitis, or LIP. Primary effusion lymphoma is an uncommon aggressive B-cell lymphoma that is associated with HHV8, frequently in patients with HIV. The imaging manifestations of primary effusion lymphoma are different degrees of pleural, pericardial, and/or abdominal effusions, normal mediastinal and parenchymal findings, and serosal surface thickening. At CT, additional findings include plaque-like or nodular serosal thickening and large serosa-based parietal pleural masses. Pericardial thickening with or without associated effusion is also frequently observed. FDG PET-CT images show avid uptake in the lesions. The diagnosis is established with pleural fluid analysis and identification of HHV8, which can be found in all cases. Let's move on to HPV-associated neoplasms. The papillomaviruses represent a large and growing family of viruses and are categorized by their oncogenic potential as high risk or low risk. Recurrent respiratory papillomatosis is caused by infection with HPV and is characterized by the proliferation of benign squamous papillomas within the aerodigestive tract. Malignant transformation occurs in 2 to 3% of patients 10 to 20 years after the original diagnosis. Respiratory papillomatosis manifests as multiple intraluminal polypoid nodules of various sizes that usually occur in the trachea. Nodules arise from the mucosal surface, and their intraluminal extent is better evaluated with CT. When the distal airways are involved, as seen in less than 1% of cases, radiographs or CT images may show widely distributed round homogeneous nodules that usually cavitate with growth. The cavities usually have thin walls, and they may have air fluid levels. Malignant transformation is difficult to detect on both CT and PET-CT. Lastly, let's cover HTLV-1 related malignancy. HTLV-1 is a virus linked to adult T-cell leukemia or lymphoma, associated myelopathy or tropical spastic paraparesis, and other chronic inflammatory diseases such as arthropathy, uveitis, and bronchopulmonary abnormalities. Adult T-cell lymphoma is a rare and often aggressive disease that develops in a small proportion of individuals who are chronically infected with HTLV-1. HTLV-1 is prevalent in the Caribbean region, parts of Africa, and southwestern Japan. There is infiltration of leukemia cells into the lung in half of patients with adult T-cell lymphoma. Common clinical manifestations of HTLV-1 include lymphadenopathy characterized by sparing of the neck and mediastinum, skin infiltration, hepatosplenomegaly, bone infiltration, general malaise, and gastrointestinal symptoms. On chest radiographs, pulmonary infiltration is characterized by ill-defined bilateral diffuse opacities. Characteristic CT findings include areas of ground glass attenuation, peribronchovascular interstitial thickening, irregular or ill-defined opacities, thoracic adenopathy, and splenomegaly. Let's recap a few key points. Viruses are increasingly being recognized as important in terms of the cause and pathogenesis of human cancers in immunocompromised populations, including patients with HIV infection and patients who undergo immunosuppressive therapy after organ transplant. Immunodeficiency-associated Burkitt lymphoma accounts for approximately 35% of all AIDS-related cases of lymphoma. The decline in the incidence of HIV-associated Burkitt lymphoma has been influenced by increasing use of active retroviral therapy. PTLD is one of the most devastating complications of solid organ transplant and hematopoietic stem cell transplant. The EBV genome is found in the majority of B-cell PTLDs, most occurring within the first year after the transplant. While the highest incidence of PTLD occurs in the first year after transplant, the time that it occurs varies between 1 month to 10 years, and rarely as late as 20 years after transplant. The clinical presentation of PTLD is grouped into 3 syndromes: infectious mononucleosis-like, isolated or multiple tumors, and widespread fulminant disease. Castleman disease is now considered to be a heterogeneous group of rare lymphoproliferative disorders. Castleman disease occurs most commonly in the mediastinum and involves primarily lymphatic tissues.